Oregon Health Policy Board meeting. We'll go ahead and get started in just 1 minute. All right, good morning, everyone. My name is Oscar Arana. I use he, him pronouns, and I serve as the vice chair of the Oregon Health Policy Board. We will start our meeting today with a couple of housekeeping items. The Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host or co-host, or they can be emailed to the Oregon Health Policy Board at healthpolicyboard.info@dhsoha.state.or.us. All materials for today's meeting are available on the Oregon Health Policy Board website, and they're hyperlinked in the meeting material column of today's agenda. Let's go ahead and get started with a roll call. So Tara, please take it away.
Hi, thank you, Oscar, and good morning, members, staff, and guests. We know that David Bangsberg is going to be out today, so I will not call his name, and we'll start with Oscar Arana.
Present.
Ebony Clark.
Here. Present. Good morning.
Good morning. Jessica Gomez. Kirsten Isaacson.
Here. Morning.
Good morning. Brenda Johnson.
Here. Good morning.
Good morning. Bill Kramer.
Here.
Sandy Sampson.
Present. Thank you.
John Santa.
Here.
Great. Thank you. We have 7 members and quorum. I will connect with Jessica to see if she can make it.
Thank you, Tara. During roll call, you may have noticed that we have a new Health Policy Board member. I want to welcome Sandy Sampson to the Oregon Health Policy Board. We are so glad to have you and your wisdom on the board. Sandy was confirmed by the Oregon Senate in mid-February as the newest Oregon Health Policy Board member. She has over 30 years of experience working in healthcare and has worked closely with OHA on health equity, Medicaid, Oregon Health Plan, 11 to 15 waivers, and many other projects. Sandy's appointment means our board has all 9 members filled, which is the first time we've had a full board in at least 5 years. Sandy, I know you had the opportunity to meet some board members and staff recently, but for those who haven't had the opportunity to meet you, would you be willing to introduce yourself?
Yes, thank you, Oscar. My name is Telti Kaun. My given name is Sandra Sampson. I'm the member of the Confederated Tribes of Umatilla Indian Reservation. I've been serving I'm going on my 3rd year, my 2nd term on the Board of Trustees. It's our governing body for the tribe. We have about 3,300 members. We employ about 1,800 employees in Eastern Oregon. I'm the treasurer of the board, so I'm a grandparent, parent, And I have one great granddaughter. So I just am very thrilled to be part of this board, this governing body, on decision makings that affect all Oregonians. So thank you for the introductions. And we go to state playoffs tomorrow, so I'm really excited. So thanks so much.
Thank you, Sandy. And we're so excited to have you on the board, and we look forward to working with you. I'm going to provide a quick overview of what we'll cover in today's meeting. OHA's new legislative equity team will join us to share about its new focus and intention for the 2023 OHA legislative concept process. Rachel Banks, OHA's Public Health Division Director, will join us again to provide agency updates on behalf of Director Patrick Allen. OHA staff will provide updates on key legislative topics discussed in February. We'll hear public comments. The OHA Behavioral Health Leadership Team will also join us to provide an update on its committee's work and address questions previously raised by OHPB members. The Healthcare Cost Growth Target Program will share updates and present a proposed approach to its advisory committee's composition. Please note that the team is looking for guidance and agreement from the board on its composition and next steps. And we'll conclude today's meeting with an update from Healthcare Market Oversight Program staff. Our first order of business this morning is to approve the draft February 1st OHPB meeting minutes. The minutes are included in your materials in today's agenda, and they're also posted on the Oregon Health Policy Board website. Can I get a motion to approve the February meeting minutes?
This is Brenda, so moved.
Thanks, Brenda. Second?
This is Ebony. I second.
Thank you. Any discussion? All right, all those in favor say aye.
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 All right, anybody opposed? Any abstentions?
I'll abstain. I wasn't part of the meeting. Thank you.
Thank you, Sandy. All right, February meeting minutes are approved with one abstention. Okay, let's go ahead and move into our first agenda item. Dave Baden, OHA's Chief Financial Officer, joins us today to preview a new approach from OHA on its budget and legislative work. Welcome, Dave, and thank you for being here.
Yeah, thanks, Oscar. Thanks, Policy Board. Dave Baden, he, him pronouns. I am the Chief Financial Officer for OHA. Good to see many of you again. And look forward to chatting about some continued work and changes that we're trying to do in OHA to continue down the path of meeting our 10-year goal to eliminate health inequities, and I think to continue to really try to make the definition of health equity realized in the agency and try to do our work differently. So next slide. So it is a little hard to sort of think about as we're still in the 2022 legislative session to think about the time it takes to put budget and legislative proposals together for 2023, which that doesn't start until July of 2023, but it's the way the budget and legislative concept process works. So, as the agency continues to work through various ways of implementing the definition of health equity, we are working on a process to recenter how we are making both concepts, what ideas and areas that OHA prioritizes and puts forward to the governor's office for consideration in development of what's called policy option packages and legislative concepts. Just for a little bit of background, those are policy option packages are budget items that get put together and budget asks that we put together that go in front of the legislator. And they can or typically are also have legislative concepts, new changes in law, new statute that would be proposed to move a particular policy or other item forward. So those two sometimes go in parallel, sometimes they're separate. And we are trying to do and change the process, which I'll talk about today, through creating a legislative equity team. And you know, I'm not sure if this is the best name for what this group of staff across the agency are trying to do, but we have staff members across all divisions and other offices, Office of Equity and Inclusion, the Community Partner Outreach Program, and others that are trying to bring together a group of staff who have really focused on community engagement over time. So we're bringing together a different group who have not had as much involvement in putting together policy option packages and legislative concepts, but what they have been working on is listening, getting feedback from community, and their life and lifeblood is about working in various aspects to make sure that all of the work that OHA has community input and is involved in that work. So the first task of this group is to help create and prioritize new legislative concepts and budget asks for what will be the next governor's first budget, the 2023-2025 legislative budget. So that process starts now in getting things ready for that work. So next slide. So I really want to start up front with a couple of points. And you know, historically, how OHA has done this work in the past has been you know, division staff and OHA leadership coming together to conceptualize, develop, and prioritize budget and policy, budget proposals and legislative proposals. It was there's forms and sort of a relatively standard process that has been in place for a long time in state government to put these things together. And only then, after the proposals were really fully developed, have some community engagement after those proposals were done. And admittedly, as the next two bullets talk about, that community engagement has not been, you know, not been sort of fully engaging, and you know, that there have been concerns raised by communities about the barriers and solutions that they see that they're facing every day in their various communities that OHA has not prioritized or brought forward. So that we have been hearing consistent feedback that, hey, OHA, we're bringing ideas and concepts to you and you're not listening. And this is partnered with staff engagement and ideas from the Office of Equity and Inclusion, and the Community Partner Outreach Program, and other staff who have also brought forward and championed ideas that they have been part of and hearing historically, and many times those also were not implemented. So the problem statement here is that yes, OHA has brought forward ideas, the way those ideas were put together, and what not really following what we have heard from community and from our own staff has led to, you know, a mismatch, or a mismatch, and not really following what what community has been asking for OHA to do, and to put forward to the legislature to you know, to try to bring new ideas and new budget proposals forward. More recently, there has been numerous community engagement sessions, and one I just wanted to particularly highlight is feedback that we received from the Regional Health Equity Coalitions, which talked about shared expectations and key values to engage them. Again, continued meaningful engagement, shared decision-making, shifting power and resources back to communities most impacted by inequities, transparency, ongoing communication, and linking feedback to action. So the legislative equity team is trying to work under these principles. And admittedly, this is the first time that we've tried to do this work differently, have a very different set of staff working on this and using community feedback to really start the process is different. I'm not sure how it's going to go. I will admit up front, we are trying this as a new way of doing work and understanding that there's a lot of a lot of procedure and process that we've got to build all of this into, and not likely having enough time to do as well as we should on meaningful engagement. Again, trying to have this as a start going forward. Next slide. Next slide, please. So the process the LET is taking to its work. So right now, they're really looking at guidance and documents that they've already heard from community. And this could be from the State Health Improvement Plan, from engagement from the 1115 waiver process, looking through the ideas that community has said, hey, we've come forward and given you these ideas, and trying now to identify major themes or topic areas, not dot every I or cross every T, and really trying to get to here were themes or different ideas to be able to come back to community, and then also work with division staff to really work on the technical issues of implementing the potential solutions. From there, you'll see in a timeline that I'll show here is to meet with community partners to review the proposals, to hear and how they understand the solution that, again, should have already been seen in the documents sent forward, but being able to check back into community as often as we can to get to what eventually will be full legislative and budget proposals prioritized that we have to send to the governor here this spring and summer. Next slide. So again, I just to highlight a couple of the limitations and challenges, the timeframes for budget development and how we substantively and continually engage community. Those two are going to be hard to keep together. The timeframes will come up quicker than it seems, and there is continued need to substantively and continually engage community in how we do this work, and statewide budget development guidance that does not wholly prioritize equity in its development. The budget guidance, frankly, how historically the budget has been created for OHA and for all state government agencies, it's all based on the past. You start with your base budget, and there's then inflation and other things, and then you build new policy and budget proposals on top of that. There's not as much look at the core budget, what it was based on, the frankly structural racism that is built into all of our budgets, OHA included in that. And so there are definitely challenges in building new concepts on something that is based on historical injustices in the state and the country. So that is most definitely a limitation and challenge on what we're trying to build on top, which is new ideas and new proposals going forward. So we are trying something different. We want to see how how we can put together with a broad set of staff, building on a lot of the good things that have been built from the Office of Equity and Inclusion, and pushing on health equity, pushing on proposals to move the agency forward, building on some work in the community partner outreach program, and then trying to build that out of having proposals being based on community input and with opportunity for bringing back to community for this work. So next slide. So here is the timeline for getting things together. This group has been meeting for the past month or so in reviewing the feedback that has been received in a variety of ways to OHA, working then to get shells of proposals that would go out in mid-April for community engagement to get into a June, July timeframe for actual policy option packages and legislative concepts to be done, and then writing narratives through the summer to get ready for the actual submission of the governor's budget in the fall. All right, so that was my discussion today. I'm excited to have any questions or comments from the board. So thank you.
Thank you, Dave. I think I saw Ebony's hand up first. Go ahead, Ebony.
Thank you for the presentation. In just listening and looking at the presentation, I found myself reflecting over the several decades that I've had opportunity within my role to participate in the budget process, and I feel hopeful and appreciate seeing an interest and a strategy and a commitment towards wanting to implement, live out, operationalize what it means to have and bring forward and integrate an equity lens into the budget planning process. And it's not gonna be perfect, and it's iterative. I think that when we think about our work, we could easily say shoulda, coulda, and wish that we would have in the past, but this is what we need to do moving forward. And so while it will be a change, it's a welcome change, and this is the direction that I believe we have to go in. And so it's going to be a process, and here we go. And so I just want to thank you for the presentation.
Yeah, thanks, Ebony. I just wholeheartedly appreciate the decades of work and feedback, and I'm sure many missteps along the way of OHA, frankly, the state not listening to that feedback. I will hopefully this will continue us to do this better, and we look forward to seeing what comes out of this that should be different. If we do this different, there won't be everything. There still is the box to get all of this into, but changing how the box gets feedback, I think hopefully will lead to a different set of policy proposals, for the next governor to see, because that's what we will be making these for the next governor to eventually decide when early next year.
Bill.
Hi, Dave. I want to echo Ebony's comments and express my appreciation for this initiative. In a previous life, many years ago, I ran a budget shop for a large state agency similar to OHA, and looking back, we were tremendously insular and inward focused, and treated the stakeholders as more as annoyances than anything else. And we have a unfortunate legacy in many states of not listening to people who were providing services to. So this is really a welcome effort. You recognize, and I agree, that it'll be a challenge. And probably the first time we do this systematic approach, we'll learn things as well. But I think you're right that this is it will improve the content of the budget and make it more responsive to the needs of the state. And I really appreciate the efforts. If there's anything we can do as a board to help your efforts along the way, please let us know.
Great, thanks, Bill.
Kristen.
Hi, thank you for this work. Good morning. I agree with everything my colleague said. I'm excited by this. I'm curious because it is trying something new, thinking about how we assess it as we're going on, especially, you know, Ebony talked about that iterative process, which I think is right. And I would, I think as we assess this program and as we help it evolve, I'd like to check in on that reflection process to ask who is doing that reflection and by what rubric. So, you know, is it to make sure that kind of the rubric even changes of what we're looking for and how we're defining success. So put that out there. And then I also wanted to, my second question, you know, I was excited by hearing about this, and I was thinking about kind of how does this input and the themes that will kind of be identified and maybe put on paper coming out of this a little more, how do those interact with the priorities given to this board from the governor and the priorities we set for our own work plans? And so how can we, and I know we have public comment and we take that very seriously, but I guess it also asks that this lens and this effort that's going in to inform our legislative priorities in our budget probably shouldn't just be restricted to then. And I would like to see how those themes and that input tie back to the priorities that we get annually or biannually from the governor, and think about that in our retreat if possible. I don't know if the timelines will be close. I don't know if it'll be close enough, but anyway, hearing some of those themes so as we think about our work ahead. I know they're on different levels of detail and stuff, but just to make sure that we as a board in setting our priorities are also in sync and listening.
Yeah, it's thanks for those comments, Kirsten. You know, I think that the assessment one is a good one to make sure that we're maybe doing more of that, and it sort of triggered a like, all right, how are we doing that piece? So thanks for that comment. And we'll get that sort of feedback piece. You know, I think that, I mean, 2 points. I mean, the messiness of doing this, and I can't think of a better word than messy, because you know, there have been a lot of documents put together, feedback from various community partners, and how then to take that and thematically group them together is not simple. And then also wanting to be, you know, like fair, and that, you know, the expertise, it is going to be that iterative hard part that frankly, I'm not exactly sure what's going to come out of that. And the group that's doing it is having struggles in what's my role? How do I have enough? How can I you know, look at this set of community feedback and feel comfortable or confident to do anything with it? I'm not not representing that community group. And so that part is not going to be easy, but I think you're right of some themes coming out of that. And, you know, whether it's a retreat or a presentation of here's how we thematically grouped, and if it leads to 5 or 10 separate policy option packages that put together off of those themes, I would see that as a pretty good success to start this year. I know the agency will prioritize highly what comes out of that work. There will be other policy option packages that get put together, but how we get to that piece. And I will admit, I think that there's risk, but I think we're willing to try to take the risk to try to do this process differently, and happy to feedback into the board to make sure that hey, this is what the agency felt it heard, and that should influence where the OHPB is going. So thanks for that.
Brenda.
Thanks so much. I also commend the work and the reframe on the perspective, the importance of it, and the commitment to moving forward in a more inclusive way. One of the things as I was just listening, Dave, that occurred to me is how important it is to grab a few stories from how we've done it in the past and how it's been broken and how we haven't listened. And to take those stories, bring them into our current reality and have them drive our future structures instead of sort of acknowledging them almost at a mental surface level and not feeling the horrible nature, of what maybe has occurred in the past. So if we bring those stories forward to today, we look at our structures differently in terms of how we want to plot for the future. So I would encourage us to use that momentum of where we've really failed ourselves as a state or as a system and use those to drive our own emotional energy to find our way through the messiness, to help us understand what are the structural flaws that have existed that some people benefited from, other people did not. Acknowledge that honestly, so it propels us to be able to move forward into the future. Because otherwise, I think we'll be, in the mess that you just described for a really long period of time until we can really anchor into some structural differences. Yeah, thank you.
Yeah, thanks, Brenda. I think that's there are a lot of, as you were saying stories, there are a lot of things going through my head of even in my 3 years of being here that I, with work during the pandemic and other budget work, it's real and present. It's not, there's history and there is today, and the decision-making, the inequities, the stories of disenfranchising and not making the decision that's helping those most at need is very real every day. So thanks for sort of that, keeping that front and center. And I think that story thought is a good way to think about it.
Ebony.
The last thing I'll just say is that, this is an opportunity to demonstrate trust, right? And, this is an assumption that I have, and, I'll own it if I'm wrong. And that's why I'm saying this is an assumption. I assume that there may be some folks who don't agree with this strategy and are questioning it. And, one thing that I always like to highlight too is that when we think about equity, whether we're thinking about health equity, whether we're thinking about racial equity, research demonstrates that when you start to kind of focus and bring forward and prioritize equity, it starts to have this, trickle down and trickle across impact. So if you, let's say you start with focusing on priority communities specific to communities of color, research demonstrates that then you also start to see impact in a positive way in terms of looking at disparities based on geographic challenges and issues, or disparities when we think about gender or sexual orientation. And so, we have to start somewhere, and it's a process, and we have to be gracious with ourselves and each other. And so, yeah, I could go on, and so thank you.
Thank you, Ebony. Other comments or questions from board members? Well, thank you so much, Dave, for the presentation. This is really exciting. This is a great direction. I look forward to hearing more from the legislative equity team in the future, and looking forward to see what policy packages they bring. I think that this is a really great strategy to help us reach our goal of eliminating health disparities.
Yeah, thanks, Oscar. I think actually, I'm glad this is being recorded, because I want to splice this piece out and send it to the team that's doing this work, because I think that your words, your thanks for trying to do this, I think will be very much valued by people who, I think, Ebony, you hit it well. It's climbing up the wall that keeps getting higher, and they're still climbing. So thanks for the kind words, and we will be happy to talk about the successes and failures as we go through this work.
All right. Well, thank you again. I want to acknowledge that Jessica Gomez was able to join us. Welcome, Jessica. Thanks for being here. All right. And up next, we have Rachel Banks, who is going to be providing some updates on behalf of Director Patrick Allen. Rachel, thank you for being here.
Yeah, thank you. It's great to be here. Hi, everyone. Rachel Banks, I use she, her, and hers. And just for visual description, I'm a Black woman with kind of heat-infused hairstyle today that is wearing a black shirt with a white undershirt. And I'm here to give some updates, as you said. Thank you, Oscar, on behalf of Director Allen. I will start there and say that we are thrilled to say that Director Allen will be returning on the 7th, is taking some well-deserved vacation time now. And so look forward to his return. But in the meantime, I'm honored to be here with you all today. So what I plan to do is give a data update and then happy to take any questions. And I don't know if folks there got the data slides from this morning, but if so, it would be great if somebody could put those up and start on slide 16, please. So if you all will indulge me, I'll pop around this slide deck this morning, and then folks will, as always, get a copy. So just in terms of where we are with our data, if we go to the next slide, this is the epi curve, which you see the huge Omicron surge there that we have, and we're coming down expeditiously out of that Omicron surge. Just to note, there's a light bluish line on over to the right on my screen, and that's just showing that for those data points that those are incomplete, and we anticipate more data that may come in with those. So if we go to the next slide, this is looking at cases. Once again, this is 7 cases, and it's a 7-day moving average over the previous 6 weeks. So an extended view here of this, us coming out of this Omicron surge. I would be remiss not to thank all of the public health workforce, healthcare workforce, behavioral health workforce, long-term care workforce, and many other workforces that I may not even know are behind the scenes working to make this happen and to take care of folks who are experiencing COVID illness. Next slide, please. These are our hospitalizations by severity. And this, you can see, once again, there's the Delta surge that was right before this Omicron surge. And the top line there is COVID-19 positive patients in the blue. The middle line there is those COVID patients with ICU beds. And then the lighter blue line at the bottom is COVID-19 patients on ventilators. So seen in Omicron, and as we unfortunately anticipated a huge increase in hospitalizations, and we know that that strained our hospital workforce, and also that there was less severity in the Omicron surge, with indicated by less patients who needed ventilators or ICU beds. Next slide. Here's just some weekly trends, so another way to look at the table. And if you'll indulge me, if we go to slide 3, I'll walk through some vaccination information. I'll do this, and then I realized what I should have done is went to age and race and ethnicity, but like I said at the beginning, I'm going to take that grace that I asked for in terms of bouncing around the slides, talk about our vaccination progress, and then we'll look at what cases look like by age and by race. So next slide, please. So we've seen, as we've done great work in getting vaccinations out there, we've seen less demand over time for vaccinations. The top is all doses there, and then booster doses are the middle line, and first doses are the blue line. We are still vaccinating folks, and particularly staying the course in our vaccination efforts, communities of color, to make sure that we're hitting or reaching our goals, I should say it that way. Next slide, please. This is people of all ages So this is another way to look at the information. The bottom line there is in the extra dose or booster dose, so about 36.5% of Oregonians, and this is of all ages, little under, well, 67% has a complete series, and then 74% is on the track somewhere with one dose. If we go to the next slide, I might breeze over the next slide. This is the information broken down by manufacturer. If we go to the next slide, we'll see a statewide look at vaccinations. The darkest blue is 80 plus. We have a couple counties there who have over 80% of their populations vaccinated. And then the lighter blue is 65 to 79, darker gray 50 to 64. And then the lightest gray, which you can see in the eastern and southeast part of the state, is 0 to 49%. If we go to slide 9, we'll see, that was perfect. Thank you for whoever's doing the slides. One more, please. These are vaccine doses administered by age group. On the bottom line, you'll see the big increase for 5 to 11-year-olds, and that, of course, makes sense as their eligibility came on board later. We do anticipate what some people call the little littles or the little peds, but the younger ones under 5 for those vaccines to be coming out in the next couple months. Folks may have known that there was a decision to do more research and study on safety and efficacy for that population. And of course, we will be ready to go when those vaccines are ready. You'll see, good trending up progress through all age groups. And, while we saw earlier it slowed, we're still making progress in most age groups. Next slide. These are vaccine doses by the rarest race and ethnicity methodology. So what you'll see at the top of this chart is the Native Hawaiian Pacific Islander population, followed by Asian, Black, and red, then white in that orange color, Alaskan Native American Indian, and Hispanic, Latino, Latina, Latinx. All groups are making progress. You will see, for example, in the Black population, with some focused effort that's made some real progress in the past several months. Next slide, please. And actually, what I might do, if we go to slide 15, this is our ticker for making progress. One more, please. Making progress towards our goal. Okay, I lied. One more after this. Towards, thank you, people remaining. So we have a goal in line with eliminating health inequities to have 80% of communities of color vaccinated. And we have been watching this, from when it was over 200 or 250,000 down, and to reach that goal. And so we still look at this and we'll still keep looking at this until we reach the goal. You can see where we have significant work to do continues in our Hispanic, Latino, Latina, Latinx population there with 53,000 folks that would need to be vaccinated to reach that goal. Why don't I pause here and see if there's any questions, and then we can look more specifically if folks are interested in terms of what COVID looks like by age or race and ethnicity, and then talk about some current policy happenings.
Any comments or questions for Rachel? Rachel, I have a question. I was I'm wondering if where in the agency is some of these successes and also challenges being tracked, and potentially like a report that will be provided to sort of do a tactics that worked really well and tactics that didn't work really well. Particularly curious kind of like hearing about some of the bright spots across the state.
Yeah, thank you for that question and that reminder of bright spots. So important. There's a couple places. I mean, from an emergency preparedness perspective, there's after action reports that come out, and that's a standard part of any time you're standing up like an incident management team or whatnot. So we definitely have those in the works. I will say we're having a conversation and we have community listening sessions and culturally specific approaches, and also wanting to make sure that we're looking back and having those conversations with communities about what worked, what didn't work. So there's a variety of listening sessions, reports, and meeting minutes, and all of that. There's also efforts this session for a bill to do reports that Senator Steiner Hayward worked on, so that there would be a look back in 3 different chunks of time. So that's one mechanism. And then I think in terms of when I think about bright spots and bright spots that I've heard folks talk about, there's a few things that stand out. Besides just the tremendous work across the workforce and people's endurance in a pandemic that has been so long. The community engagement efforts. I was at a community listening session where people really acknowledged, and from a variety of communities, that the relationships with OHA have been strengthened and the trust has been strengthened. And of course, we want to see that continue. And folks acknowledged, however many months ago that there were challenges, and now we've made real progress there. So the folks who work in community partnership and outreach program have been doing phenomenal work for decades. The folks who work in my community engagement colleagues, folks who are working in equity and inclusion, great work. Also the field operations, if you will, that were distributing PPE when needed. And that PPE was COVID related, and it was, wildfire related or heat related. They just really have been able to pivot. Vaccinations, testing. So I think that has been, the whole regional structure has been another real bright spot. And then of course, we're continuing to work with partners across the public health system.
Thank you, Rachel. I really hope the legislative equity team is also embedded in some of these like community engagement discussions. John.
Yeah, Rachel, you may be going to address this next, but first of all, I think really Oregon's done a great job of responding to what a year ago was a really challenging picture. For a while, I followed vaccination rates in the African American and Hispanic communities. And for months, OHA increased the rate every day, tiny bit, but that just kept going up. And I think there's a story to tell about how you did that. And it would be good sometime, because hopefully what you learn can be used in other areas where there are disparities that are just as striking. But as I look at your data now, and again, since I'm 71, my bias is to ask, it looks like there may be significant numbers of people over 65 in parts of the state that have not been vaccinated. I think the difference between Multnomah County, Washington County, and those Eastern Oregon counties is striking. People deserve the right to not be vaccinated, but you have to be concerned. Do the people over 65 really understand what's going on, and are they making a well-informed choice? And are they aware that they are the population that's at risk of dying here? Because that continues to be the case. So that's my major concern. Those folks now seem to me to be the most at risk.
Yeah, thank you, John. Appreciate that. And in terms of telling the story, it just gave me an idea in terms of working on inequities and what's been done and having that conversation with community to really document the efforts and that to be told. I will say, just in response to that part of the comment, I think having culturally specific efforts where, you know, we're seeing an issue and really tackling it from that perspective and letting community say these are what the issues are and this is where we need to move and pivot, and has been really pivotal. I absolutely with the age piece and vaccinations, and we are going to, like, that remains our, you know, one of the best tools that we have. And we know that disease severity by age, unfortunately, our deaths by age, those are all things that have borne out that are worse for folks over 65, as you've mentioned. If we want to look at cases by age for the slides, that starts on slide 24, and we can take a look at that. But I think to your point, you know, continuing to make sure that folks have capacity across the state is definitely top of mind. Seeing gaps across the state has always been a concern. So this is pediatric cases, and this is looking at community transmission by county. In a minute, I'll talk about the CDC framework if time allows, but you'll still see, according to this, that community transmission is high and substantial across Oregon and varies by age. I will just say a disclaimer that the CDC framework has changed, so the map looks different now, and I'm happy to get that information out to you.
Rachel, really quickly, I see Sandy's hand is up, so I want to make sure Sandy's question is raised.
Yeah, my question's in regards to self-testing now, and then the data that, how relevant will the data be if people are not actually sending information, whether through its OHA, your community public health outlets, or even tribal organizations. So, you know, it's great that, you know, we see this data, but that could be a big game changer down the road. You know, there's a new variant that comes out or something. So I guess my concern is, you know, is it the data that's being reported, is it going to be equitable for really determining what is happening in Oregon after, you know, March 11th? We still have the vulnerable population of kids 12 and under that, you know, lifting a mask mandate, is that, you know, a sensible choice? Are we going to mandate healthcare facilities or childcare facilities to still have their employees wear masks? I guess it's just a concern because they are, you know, there's nothing out there until maybe the end of April for children 4 and under. So that's my biggest concern. So thank you.
Yeah, thank you. And within that, Sandy, you reminded me that I should have mentioned something about the data. So thank you for that. And then happy to talk about where we are with the schools population and just lifting of mask requirements. So yeah, with the increase in self-testing, we do know that the case information, that we're not getting all of the tests. There is a way for people to call in and talk to us. So there's a hotline for folks that self-test that then want to call in, but we know that case information is not capturing all of those home tests. The thing that we have and will continue to really look at is those hospitalizations as a marker, you know, irregardless if folks were going to get sick enough from COVID, whether we knew that they had a test or not, that could show up in hospitalization. So that is one of the things that we focused on, but also the Centers for Disease Control has really prioritized in their risk framework that they released, maybe it was last week. So keeping an eye on those hospitalizations remains really important, knowing that we may not capture all of the tests. In terms of, so the CDC framework did a number of things. It created classification system by county that includes hospitalizations and a variety of other things in low, medium, and high. And their recommendations for things like indoor public masking was tied to that, would continue in counties that were high. That was the recommendation. And for populations with underlying health conditions, populations that are not vaccinated, populations that are over 65, for example, or populations that live with folks with one of those risk factors. So continuing those mask recommendations there. So what that would mean for Oregon is we have counties in different places in that. And as folks have heard, I do get my days mixed up. I think it was the 20, I don't even know, which was yesterday. So there was an announcement by the governors of Oregon, Washington, and California to really pursue a united approach, a thoughtful approach to lifting masks in schools and the general public March 11th. So what we are doing in the meantime and have been doing, so Oregon Department of Education, working with Oregon Health Authority and districts across Oregon, is really preparing for that in school settings, walking through what are the safety protocols in schools going to be, finalizing what testing will look like, what notifications will look like. And of course, in all of this, we want to create an environment that is conducive and is supportive for those folks, students, parents, folks in the community who want to continue to wear masks. So we'll be providing all sorts of communication support, technical assistance support to those so that people can continue to mask and feel like that if that is something that they want to do. But we will also be working to continue safety protocols in schools and making sure that the goal of having children be able to remain in school and learning is paramount for all of us.
Well, I guess my point was just looking at your maps and vaccination rates. Eastern Oregon is the lowest on this side of the mountain, so that's my concern. So thank you.
Yeah, thank you. And we can get out also the CDC map. There are parts of Eastern Oregon that are in low risk according to the CDC's new framework. But I will definitely acknowledge that the maps don't totally align in terms of risk, support, and where we in vaccination rates.
Any other final questions or comments for Rachel? Rachel, do you have an update on when Director Allen might be returning and how he's doing?
Yeah, so Director Allen will be returning on March 7th, which I believe is next Monday. So we are excited to have him back, and he's taking some vacation time now. He said my dates have been. He was back and working some hours with us a couple weeks ago, and then took some well-deserved vacation time. So he'll be back on Monday.
Great, thank you so much. That's great to hear, and thanks for stepping in and providing agency updates while he's been away. So thank you.
Pleasure. Thank you all.
All right, so last month we heard legislative updates from OHA's government relations team. There was a lot of interest in the workforce bills and Oregon Health Plan redeterminations. Today, we're joined by staff to hear an update on these two areas. Please note the legislative short session is still very active, and anything that is shared and discussed today could change over the next week. Neelam Gupta, Director of OHA Clinical Supports Integration and Workforce Unit, and Mark Overbeck, Director of OHA's Primary Care Office, are here to provide us with workforce updates. Please take it away.
Thank you so much. for having us today. We're excited to share with you some workforce legislation updates during the short session and next steps. Obviously, the workforce has been an issue of great interest given the multiple workforce crises that we have been experiencing. Next slide, please. So today, we just want to highlight this set of 8 key workforce bills. We have also included in your packets a workforce legislative summary crosswalk, which is organized by new workforce development programs, bills that establish or create a new program, as well as scope of practice, licensing or payment issue bills. And those are indicated by their impacts on the healthcare provider incentive program, alignment with House Bill 2949, and any impacts on physical health workforce, oral health workforce, and behavioral health workforce, and also addressing a need identified in last year's healthcare workforce needs assessment. I will mention that we are going to be reviewing out of this list of bills. We are going to be providing more information about 5 of them, organized by the role that the Oregon Health Policy Board can play, kind of provide a brief summary of each bill, any implications for OHPB, as well as equity impacts. I just want to quickly mention the 3 bills that we're not going to be covering. The first, which is it's House Bill 4096, temporary authorization for providers, authorizes specific healthcare providers to practice in Oregon without compensation for a specified number of days without obtaining licensure. The second bill is Senate Bill 1549, which provides temporary staffing agency authorization and adjusts rates allowed for paying temporary staffing. And the third bill is House Bill 4095, which establishes the Veterans Dental Program in OHA to provide oral health care to low-income veterans who reside in Oregon beginning in 2023. So next slide, please. My colleague Mark and I, we're gonna alternate for some of these updates, but the big bill, which really signifies a multi-year effort, is Senate Bill 1545, the governor's workforce package. This bill is, a tremendous investment and really an outgrowth of the work that the Racial Justice Council has been doing. A $200 million investment in workforce across 3 sectors, including healthcare as well as manufacturing and technology. This bill provides very, very significant investments in a program that was originally its own bill and folded into Senate Bill 1545. It provides workforce ready grants. It has a large investment in apprenticeship and pre-apprenticeship programs, as well as youth development programs. There's also a recognition of the importance of building the pipeline and providing credit for prior learning. And then also creation of industry consortia, which also includes community involvement through the Racial Justice Council. And this funding is a mix between ARPA funding and general fund funding. And so this is, a huge investment. We in our unit were able to include a staff member to support alignment for the workforce committee with the workforce system investments to ensure coordination of resources. This funding is going to the Higher Education Coordinating Commission, and a lot of it is going to the workforce boards. And as you can imagine, the equity impacts are considerable from this. And yeah, thank you, Tara, for defining ARPA is the American Rescue Plan Act. And then I'll pause here and see if Mark, you wanted to add anything to that summary.
Thanks, Neelam. I think you did a terrific job in laying out the overview of the Future Ready Oregon Workforce Package. Tremendous bipartisan support. And we're really excited to be able to work alongside of our partners in the public workforce system, the Higher Education Coordinating Commission, to help align all the resources that we have with OHA, our subject matter expertise, and to really work effectively for supporting the workforce and diversifying the workforce in the healthcare sector. Of 3 sectors supported by this bill, manufacturing, technology, and healthcare.
Great, thank you, Mark. And I'll also mention that Mark also has an ex officio appointment to the Oregon Talent and Workforce Development Board. And so this staff person will, allow further alignment with this really significant and needed investment in workforce. Next slide, please. HB 4003, House Bill 4003, is a bill that focuses on nursing study, nursing wellness, and nursing interns. We see the Oregon Health Policy Board role as that of a supporter. The summary of the bill is that it authorizes student nurse license for nurse interns. It funds a $500,000 program for nursing wellness, given all the issues that we've seen and that nurses have experienced throughout the pandemic with burnout. And it directs the Healthcare Workforce Committee to study and report on nursing staff shortage issues by November 15th of 2022. So a pretty quick turnaround in preparation for the long session next year. This bill obviously, has implications for OHA's work as well as OHPB priorities. We are in the midst of planning for the workforce study and report. And the equity impacts, are likely to underscore the need for more work on diversifying the nursing workforce. And again, Mark, I'll turn this over to you because you've been tracking this bill more closely.
Sure, just a couple of other things. This bill, as many of you know, was the culmination of efforts made by Representative Rachel Prusak and a work group that she combined to bring different legislative concepts to the short session that began almost as soon as the 2021 long session was finished. And as Neelam said, part of this bill is that the Workforce Committee is to study and report back in a pretty short time around nurse staffing issues. We are ready, like we are with Future Ready Oregon, to hit the ground running. We have secured some funding for a consultant to help us do this work. And we're meeting with the leadership of the Workforce Committee, which has included Brenda, to speak about how we go about doing this and not alter or push aside the rest of the important work of the Workforce Committee. So we have a general game plan for getting to November, and we're very excited about this as well. I think we can move on to the next bill.
Great. House Bill 4004 is another very significant investment in the immediate behavioral health workforce crisis that creates $132 million in grants to behavioral health treatment providers for recruitment and retention. And this bill also, has a very quick turnaround that the grants should be distributed by May 31st. We are unsure of the role of OHPB with this bill. Our colleagues in the Health Systems Division, Office of Behavioral Health are taking the lead, but there are some potential changes or implications to our work. It is likely that the Behavioral Health Metrics Committee may assess the results of the impact and report to the board. And it is also possible that and an open question about what sort of role the Workforce Committee would play in this. And the equity impacts, again, are really driven by the immediate workforce crisis and the potential for greater access, shorter wait times, and more culturally responsive services. And then I'll turn it over again to Mark and see if he wants to add anything.
Yeah, again, really, really great, Neil. The one piece I would add is that while absolutely this bill is a solution to the immediate workforce crisis, since the grants to the treatment providers can be used to supplement wages and other recruitment and retention activity, it does potentially have medium to long-term effects as we look to get out of the pandemic and how do we go back again to the work at hand and not just responding to crises, but building back the workforce, expanding the workforce, ensuring that we have a workforce from the treatment level to the mental health level to the doctorate level of healthcare professionals that are providing culturally specific and culturally responsive service. So yes to the immediate crisis, and potentially if we can take advantage of this, it may show also a pathway for the future.
Great, thanks, Mark. Next slide, please. And then Mark, I'll let you cover these last two bills.
Sure. The last bill that we're sharing with you that either has passed or is likely going to pass is House Bill 4071, which revises the original language of House Bill 2949 when the bill initially spoke to who is prioritized to receive service and receive subsidies. There's been considerable discussion among the staff at the Department of Justice, the Attorney General, in light of recent court cases and judicial rulings about how public funds can be targeted legally in language at communities of color or priority communities. And I know that our Department of Justice has been working directly with Pat and Don Jagger to ensure that we are legally covered around the language we're using to advance our efforts around anti-racism, advancing health equity, ensuring that we really have a healthcare system that is accessible for all people, like for really everybody. So this is a language change, and it's been vetted, as I said, for many, many months at the director's office level and with the staff in the Department of Justice, and the legislature understands. So they're making these language revisions. In terms of the role, I think a communicator for OHPB to understand about this. I'm not an attorney, Neelam's not an attorney, and you may have other questions, but the real implication, no substantive changes. We are very clear in OHA, and you are clear as a board of what it is our charge, and we're looking to be able to advance that work.
Great, thanks, Mark. I think there's one last slide. Oh, sorry, Mark.
Yes, yeah, no, just on the last slide, great. So we are actually bringing to you today one bill that's not passing. You may think, well, why are they bringing a bill that's not passing the session? This is directly from the work that you've done many years ago in your workforce committee. And this has to do with the opportunity to take advantage of the roughly 1,100 naturopathic doctors who are licensed to practice in the state of Oregon. Back in 2013, the workforce committee authored a recommendation to the board and the legislature to maximize the opportunity for the naturopathic profession to assist in primary care. As you may know, naturopathic doctors, NDs, have years of training required. The residency requirements are actually more than that of some other primary care health professionals, and there are roughly 1,100 of them. This is the third session that the naturopathic community has come seeking an equal reimbursement to that which is provided for physicians, MDs, and DOs, for nurse practitioners, and for physician's assistants for the same service. And currently, while NDs are credentialed by the state of Oregon, they have a licensing board, they may be credentialed by various carriers. The recent studies have found that their compensation, the reimbursement, is roughly 50 to 60% of those other disciplines that I mentioned. This bill got through the policy committee as well as it did the previous session, and has some strong legislative champions. However, it looks like this bill, once again, is not passing. The role for the board we see is that of being aware as a communicator. There will be no substantive changes to the board's work or the workforce committee work out of the non-passage of the bill, and potentially the equity impacts. No, you ought to review what are the primary care FTE throughout the state. How are we doing with the goals around workforce diversification and access? When you have a state with workforce shortages and 1,100 providers may reduce their time or leave the field altogether due to frustration around compensation, there may be impacts. So Neil, anything you'd like to add on House Bill 4006?
That's great. Thank you.
Thank you, Neelam. And Mark, do we have any questions from board members?
I don't have a question, my comment, and I know that like we all get it, but I just want to say this, that I think it's about long-term investment, and I recognize kind of the strategy in terms of being able to leverage every opportunity and be able to kind of bring forward opportunities that have the most immediate impact. And so I just continue to hope that we also see strategies that have resource that will help with sustained long-term revenue to continue to attract and retain highly qualified individuals to provide care. So
Thank you, Ebony. Any other final comments or questions?
Oscar, if I may just respond to Ebony, thank you so much for bringing that up. I know that Brenda is certainly aware, and I believe most of you board members are aware of the work that we've done over the past several years, even before the pandemic, even before House Bill 2949 and the real acute crises. Right now, our office is already supporting close to 600 clinicians receiving federally funded incentives that are available because of the work that we do. We have 300 clinicians receiving state-funded loan repayment and scholarships under the Healthcare Provider Incentive Program, and about 400 others that are receiving other state-funded workforce subsidies to support their working and remaining in Oregon, in rural Oregon. And absolutely, this is not simply about responding to a current crisis, but looking out for the long term. I think this is all about how do we continue to elevate our capacity, and we need the resource, but we're really committed to elevating our capacity to get this kind of work done in a way that's meaningful, that's responsive to the communities that we're dedicated to serving. And frankly, as we come out of the pandemic, we're now in a new environment where the strategies that we have been able to use and been successful with may not work quite the way they used to. So, Ebony, thank you for calling out the need for ongoing resources. And I'm taking by implication the need for us to be thoughtful, strategic, looking forward at what really is going to work for the long term.
John?
Yeah, in large part, I see the world through the lens of what I read, because I'm not able to really get out and about that much. But what I read when it comes to nursing seems to me that this is an extraordinary time, that what's happened because of, the travel nurse phenomena has just turned nursing upside down. And maybe it should be, because I think nurses have long been underpaid, underappreciated, and deserve to be more of a priority than they are. So in the future, I would be interested in knowing how Oregon is faring when it comes to what I think is a national redo of how we relate to nurses.
Thank you, John. I am going to hand it over now to Jeremy, who's going to provide some updates about redetermination.
Great. Thanks, Vice Chair Rana. I think we got you an update last month, and a lot has happened in the last month during the legislative session. So I want to bring folks up to speed on how the conversations quickly evolved. I think when we spoke last month, there may not have even been a legislative concept or a bill number, but we've been working on this issue with Chair Prusak, who's chaired the House Healthcare Committee, and a variety of legislators and stakeholders over the last month, and that bill is now slated for a floor vote tomorrow in the House. I want to go to the next slide. We do have a bit more background on the issue that I think will be helpful for the board to hear, as well as where this issue is going generally. And we kind of crammed this into the legislative update this morning because we've got a packed agenda, but recognize this is probably an issue that the board's going to want to hear about on a regular basis, and happy to keep the conversation going and provide more information offline if that's helpful. Next slide. So just a reminder, the challenge that's ahead of us, and one of the early congressional coronavirus relief packages that passed Congress, they created a national continuous coverage policy within Medicaid. And what that really meant was, in exchange for states getting enhanced Medicaid match during the pandemic, all states adopted a policy of, for the most part, not terminating coverage for folks for Medicaid, with some exceptions. By and large, we've been doing eligibility redeterminations wherever we can, but largely have not been ending coverage for folks. What that has meant is that about the Oregon Health Plan enrollment has grown from about 1.1 million to 1.4 million during the pandemic. This is all tied to the end of the federal public health emergency. And when that public health emergency ends, we'll go back to sort of the pre-pandemic world of all members having an eligibility redetermination every 12 months. And for those who no longer are eligible or don't respond, generally we'll lose coverage. And we're estimating about 300,000 people will come off of OHP when we go through that process. Next slide. As we talked about last month, sort of a good news, bad news story here. The good news is that we have the lowest uninsured rate we've ever had as a state as a result of this policy. The uninsured rate dropped from 6% to 4.6%. We also saw not across the board for every community of color, but we saw for Black African Americans in particular a huge drop in the uninsured rate from 8.2% to 5% during the pandemic. You can see what happened kind of on the whole within the health insurance market. Employer coverage has been continuing to tick down as it has been for the last 10 years. And so the Oregon Health Plan gains largely came from folks who lost employer sponsored coverage and from folks who were uninsured. We think this a large part of the folks who came on are folks that are really bouncing back and forth between different types of insurance coverage or becoming uninsured as their income goes up and down as they're right on the edges of Medicaid eligibility. Next slide. We also saw that the largest gains were in folks who are in that income bracket right above Medicaid eligibility. So on the left shows the different poverty levels, different income brackets. It's Medicaid for non-disabled adults largely ends at 138% of federal poverty level. And you can see the gains were largely almost entirely with folks who were in that next income bracket up from 138 to 200%. We've largely suspected and talked about this being the churn population, the population whose income is fluctuating and they're going back and forth between Medicaid and commercial insurance. But this really confirmed that really is a churn population within that income bracket who really is going in and out. And as we've stabilized coverage and had continuous Medicaid eligibility, those folks have gained coverage and had it consistently. And we also saw an enormous drop across the board and folks reporting losing Medicaid as being the reason for being uninsured. Another data point not on the slide is that before the pandemic, we were measuring how frequently or how quickly people leave Medicaid and then come back in a relatively short period of time, a couple of months, 6 months, a year. Before the pandemic, about a third of all of the applicants in any given month, we had about 25,000 people applying in any given month. About a third had been on OHP at some point in the last year, and about 25% had been on some point in the last 6 months. That's about 100,000 people, or almost 10% of the caseload that was going off and coming back within a year. That's basically stopped during the pandemic. Largely the only folks that are coming on are folks who have never been on Medicaid or haven't been on for several years. So the good news, bad news is good news. We've gotten coverage really stabilized for folks, especially low-income workers who are on the edges of Medicaid eligibility, and we've reduced at least one major inequity. The bad news is I think we're all really worried as the legislature that if we just go back to the world as it existed before pandemic, we just go back to higher uninsured rates for communities of color, and a churn population that's going back and forth in and out of Medicaid with care disruptions. So this is the conversation we've been having with the legislature. This session is, as we approach this 12 months of redeterminations, what can we be doing to learn from this and to really try to preserve coverage and minimize disruption for folks. Next slide. Next slide. So what's emerged is House Bill 4035, which really does two things. One, it sets the direction for how we go about this 12 months redetermination period that states are going to have to basically catch up on eligibility. And then second, creates a task force to develop a new bridge program that would create a more affordable health plan option that would provide continuous coverage for folks that are in that churn population. And as we're going through and finding folks who are in that 138 to 200%, having a better landing pad for them that allows continuity of coverage, specifically through their CCO and leveraging federal dollars that would otherwise be in the marketplace to help folks basically stay where they are if they're churning in and out of Medicaid, as opposed to having to continuing to change plans. I'll go through both of these step by step in the next couple of slides, but the bill also lays out a number of milestones throughout this year and next year for reports back to the legislature on both of these paths, which really will be related but parallel paths of work. Next slide. So on the redeterminations process, independent of the bridge program, which would require a task force to come up with a waiver application and approval from the federal government, we will have to do the redeterminations regardless. Every state is going to have 12 months to do redeterminations. Our normal process would be basically take the 1.4 million folks on OHP, somewhat randomly distribute them over the course of the year. That would be about 120,000 folks every month that we're needing to do eligibility redeterminations for, and about 25,000 closures. This is the process we normally go through. I think the terrifying part of this is thinking about 25,000 people losing insurance and really smoothing that out and having enough time to do outreach and making sure that we're trying to minimize the people who are losing insurance because they didn't respond or we didn't have updated contact information versus losing insurance because they truly are no longer eligible. So the approach that we've mapped out with the legislature is to do this a little differently than we normally would do it during this 12-month catch-up period, and that would be really to take a phased approach and phased populations based off of risk level in essence, and front load a lot of the easier cases that we think we'll be able to do through an automatic enrollment, folks who have a higher confidence level that we've got updated contact information, and sort of backload the folks who we feel like we need to do more outreach to be able to make sure that we can get updated contact information, folks who are higher risk in terms of health conditions, and make sure that we've got more time to be able to smooth that transition for them, as well as to hold on to folks who are in this churn population until we can have the new churn program up, and then slide them into that eligibility category. Then separately, the bill calls for a task force that will be on a really aggressive timeline from March through July to leverage either the basic health plan authority under the Affordable Care Act or a 1332 waiver. These are two new waivers that were allowed under the ACA that have been somewhat minimally used to basically be able to take the dollars that would normally go to premium tax credits to help folks who would be going in and out of Medicaid basically just stay where they are. So rather than needing to go from Medicaid to the marketplace and back to Medicaid, in essence, create a capitation rate that allows CCOs to continue to provide coverage up to 200%. Next slide. So I already mentioned most of this, but on the redeterminations piece, the bill also allows us to some flexibilities that we don't normally have. Allows more time for us to build a longer timeline for folks to respond to information. Usually, we give people 30 days to respond to information. The bill gives us the ability to stretch that out to as long as 90 days. So we've got more time to be working with CCOs and community partners to be trying to find folks who are not getting a response from. As I mentioned, allows for us to do a phasing of populations. And so when we talk about higher risk folks, thinking about, as I mentioned, folks who might be eligible for the bridge program, folks with specific health conditions or other circumstances, that we really want to make sure that we're buying as much time as we can to do smooth transitions with those folks. Next slide. As I mentioned, the task force will be up by the end of March, and we'll have till July. There's really two main flexibilities that we're looking at. One is it's called Section 1331. This allows states to create what's called a basic health plan in the Affordable Care Act. There's two states that have done this, New York and Minnesota. And really what it basically allows is states to take, the federal government basically has a formula where it would take it will deposit into a trust fund for the state the dollars that would otherwise be eligible for tax credits in the marketplace, and allow the state to basically pay for health insurance out of that. So what Minnesota and New York do is they basically have created a capitation rate for their Medicaid managed care plans, and what that allows is a zero or no cost plan, a cheaper plan for Medicaid. And the way they get there is they basically set a reimbursement rate for providers that's somewhere between Medicaid and commercial, that allows the state to have a health plan that operates within those federal dollars at lower cost. The biggest drawback, I would say, of the basic health plan, or at least some folks would see as a drawback, is the ACA says if you create this, basically that's the one option for people for between 138 to 200%. They don't have the option of Medicaid or the marketplace. We estimate there's about 55,000 people in Medicaid, or that there will be about 55,000 people that we identify in Medicaid in this income bracket. We estimate there's about 30,000 people in the marketplace. So either want to be able to have the marketplace still be an option for folks who want that option, or buy enough time for a transition to really be able to do this over a period of time. So looking at coupling that basic health plan option with a 1332 waiver, which is a separate waiver in the ACA that Senator Wyden was really the champion of, that was aimed to allow states to just basically take federal dollars that would be under the ACA and do something more creative with them. So the conversations we're having with CMS are, can we couple these two together and basically create an Oregon solution that really creates a better set of options for folks in this 138 to 200%. Next slide. We've also talked with CMS about the ability that if needed, we could do a temporary extension of Medicaid eligibility to be able to really hold on to that 138 to 200% while we get this bridge program stood up. There's some budget impacts of that. And so want to minimize the use of this as much as we can and be able to switch over to the full federal funding as soon as possible. But this is an option for us as well. Next slide. Overall, the timeline is looking like this. This is all dependent on the timing of the public health emergency ending, which right now is slated for the middle of April. I think at this point, we're all expecting it's going to be pushed out until July, but we have not received the formal notice of that. So imagine this timeline just sort of moving forward in 3-month increments each time they extend the public health emergency. But there's really kind of two tracks here. Up above is the redetermination work that we'll need to be doing. The bill calls out for us to have a community partner work group and develop a plan back to the legislature by May on how a more robust description of how we will approach this redeterminations process. We expect folks will generally fall into 4 categories. Folks that we can't get a response from. As I mentioned, we want to draw out some of those timelines to allow more outreach, but eventually if we're not getting a response from folks that we need a response from, they would eventually have moved to being disenrolled. Well, folks that are above 200% of the federal poverty level, those folks will be handed off to the marketplace, and Chicky Flowers' team is geared up to be doing outreach with those folks. Folks that are under 138% or otherwise eligible for Medicaid will be determined eligible, and then they'll fall into the normal annual cycle. And then the folks that are in this bridge category, what we'll do is hold on to them until the end of the redeterminations process. In the meantime, task force will be developing this proposal to the federal government by mid to late summer. Expect to submit an application this fall to CMS, be in negotiations and approval, and hope to have approval in Q1 or early spring of 2023. And at that point, be able to really basically have contracts in place with CCOs to be able to continue to provide coverage for folks up to 200%. And really the real change would be administrative behind the scenes. We would move folks basically from Medicaid funding to the new bridge plan federal funds, that hopefully really a seamless experience for members. And the only thing that's really changing is the color of the money. We're having really good conversations with CMS. We're on a cadence of weekly meetings with them. They're very committed to helping us work through options. There are some legal challenges that I think we'll need to be working through the task force, where we might prefer to go left and we can't quite get there. So we're trying to work through those options with CMS, and like I said, they've committed to basically be working with us in parallel to this task force, so that we're vetting in real time options as we're putting together the waiver application. Next slide. Next slide. I think I'll end there, and happy to take questions. I will say, I think looking at this churn population bridge plan, when we think about the investment that the legislature made around Cover All People last session, and thinking about a bill now to create a bridge plan for folks who've been cycling in between being uninsured and Medicaid. Those are two really significant populations within the 6% who had been uninsured before the pandemic. And I think these two strategies coupled together would really take us a long ways as a state towards our universal coverage goals. So happy to take some questions.
Thank you, Jeremy. John.
Yeah, thanks, Jeremy. You have a lot of balls in the air, and I admire you for keeping them all up there, and really appreciate this effort. The one question I have is on slide 19, when you, this line where you describe over 200% of the FPL off to the marketplace, is that going to include people who are in the midst of significant healthcare episodes? Is it going to include people who are within 2 or 3 months of becoming eligible for Medicare? Are you going to do anything in that group, to minimize the potential disruption in the subset that may be very vulnerable?
Thanks, John. So when we talk about phasing populations, the examples you give are exactly the types of things that we're thinking about. So folks who are really close to Medicare eligibility, trying to think about maybe pushing them towards the back of the process so that they don't have to make two switches in a short period of time if we can identify who those folks are. There are mechanisms for folks who are in the middle of treatment, and their eligibility redetermination comes up to identify them and to not have a disruption in treatment and to go through that eligibility redetermination on the other end of treatment. So the work ahead of us is identifying more of the details of what those populations exactly will be and trying to find folks. But I think those are very good examples of what we're talking about in terms of trying to put some of the sort of easier cases on the front end and allowing more time for outreach and work on continuity of care for folks that are higher risk.
Any other questions for Jeremy? Sandy.
So Jeremy, when you're doing your 1115 waiver and you're looking for budget neutrality, with that said, and working with the one eligibility program and the redetermination of anyone at that 138, they're automatic. So when you're renegotiating with the CMS, and this won't be, I guess, just the time frame that you're dealing with, and this new program called the budget or the bridge plan. Is there a copy of the bridge plan? Or are you still actually developing that?
Yeah, thanks, Cindy. So we're still developing it, and we've got a rough concept that we're getting down on paper, but there are some key details that this task force is going to need to really work through. Things like how important is it that and is it good or bad that there's an option that people could stay in sort of with their CCO or the marketplace, and what are the pros and cons of that, and how important is that for us to push with the federal government. So there's some real key decisions that this task force is gonna need to make. We have a basic concept, which is really to take the federal dollars that are available in the marketplace and in essence build a capitation rate for CCOs, and the vehicle for that could be basic health plan or 1332. But there are a lot of details still to be sorted out. With that said, as I mentioned, CMS is really very much committed to helping us work through that. They've committed to a really tight timeline over the next couple of months for us to be able to really understand what's possible and not possible, so we can feed that information into the task force's work. In terms of timeline, I mean, I think maybe where you're headed is how does this interplay with the 1115 waiver? This would be a separate set of waivers. So it's a parallel set of conversations with CMS. Mm-hmm. They're very much aware that we've got a lot of conversations with them happening. And on our end, we have these two teams connected. It's a lot of the same folks that are working on, for instance, the 2-year eligibility within the 1115 and how that interplays with this. But at the end of the day, we're really talking about two different waivers, and frankly, some different parts of CMS than we typically work with on the 1115. So they'll be happening in parallel conversations. The timing of it is we're expecting to have the 1115 waiver approved by around Labor Day is what we're aiming for, and expecting that this bridge plan would be approved in Q1 of 2023 or early spring. So it's a fast timeline, but as I mentioned, I think, CMS very much is, I literally quotes from them in articles have been things like they go to sleep and wake up thinking about redeterminations. This is front and center on their mind. And so I think they're very committed to helping us find a solution, and something that could be a solution for other states as well.
Okay, thank you.
Any final question or comment from board members for Jeremy? Kristen.
I just wanted to say I'm really excited that we're taking this on and really kind of tackling not only the challenge that we have to do here, but saying how do we maintain a low uninsured rate, and how do we keep stepping forward as a state with our healthcare. So I know it's daunting and hard, and the timeline is so compressed, but I just wanted to appreciate all of the efforts going into it.
Yes. Oh, Sandy, another comment?
Sorry, I just have one question in regards to the tax credits and then the auto enrollment for CCOs. I know we've had some problems with auto enrollment, and tribes don't have to be auto enrolled. So I guess, how is that going to play out when this is developed for auto enrollment with CCOs?
Thanks,
And
Sandy.
the opt-out option. Okay.
Thanks. That's a great question. We're expecting to engage with tribes on a parallel track as well with the task force. And actually, the bill, we built that into the bill. We would do it anyway, but want to make it really explicit that we'll be doing tribal consultation throughout this process to work through details like that. And I think really would take the tribe's lead on how that should work. I think for for folks that are already in a CCO, the idea is to provide continuity of care, obviously with the ability for folks to opt out or still have choice, but in essence, want to be in a situation where we're finding folks who are between 138 to 200%, rather than saying, if you do nothing, you're going to become uninsured. If you do nothing, you're going to stay right where you are. I think, there are some questions in that, as I mentioned, do folks still have the option to go to the marketplace if they'd like, is a question. We still have open card folks who aren't in a CCO. And so where do those folks go? So we still have some details to certainly to work through.
All right. Well, thank you so much for your presentation, Jeremy. I also want to thank Neelam and Mark for their presentation as well. And thank you so much for all your work. We are going to take a shorter break than usual to get us back on time as much as possible. So let's go ahead and take a break and come back at 10:25 a.m. Okay, we're going to get started again. We don't have anybody signed up for public testimony this month, so we're not going to have public testimony today. So we'll just go ahead and move right into our behavioral health update. OHA's behavioral health leadership team joins us again to share its progress since we met them in November. Thanks for coming back. We understand you've been very busy with the surge and legislative deadlines. So thank you for being here, and please go ahead and start when you are ready.
Thanks, Oscar. Can you hear me?
Yes, we can hear you.
Awesome. Yeah, I usually start on mute, so it takes me a time or two. Well, thank you for inviting us back. And I have some ground to cover, and I'm accompanied by Leticia Sains and Colleen Zimber, who you met back in November, to pinch hit on some particular areas where you may want some additional detail. What I would like to do is to spend about a half an hour and give you an update on sort of what's going on in our neighborhood, which is a lot, as you suggest. And then back in November, there were some questions that arose from that discussion, and we're prepared to spend a little time on those questions or anything else that you'd like to talk about today. So if it's all right with everyone, what I'd like to do is just sort of move through these slides fairly quickly and then take questions at the end, along with highlighting the other questions that you raised back in November. Next slide. So this actually is one of the questions, the remaining questions. I think there's 8 in total. The remaining 7 are at the back of the deck, just to remind it. Park this one at the front end because it really has to do with this build out of the infrastructure, the workforce, and other initiatives that you'll see more detail on. It's part of the deck, and it's essentially, you know, are we trying to do too much too fast? And probably the short answer to that is yeah. But we'll get into that in a little bit more detail. I want to create kind of 3 buckets as we think about this presentation today and the work that we have going on. We'll spend a little time in what I'll kind of call the crisis end of things, which is the behavioral health crisis and more broadly healthcare crisis that we're in at the moment. As you know, hospitals and all other healthcare resources are providers are really struggling right now. Workforce is exhausted. We have a really general workforce crisis, so it's Starbucks all the way through the hospitals, and it certainly includes behavioral health. I think a really precise word right now in behavioral health is our system is really fragile, and it doesn't take much for things to get worse. And we've been working really hard to support the behavioral health infrastructure as we move through this, and we've been moving at the speed of all deliberate speed and urgency that this crisis and this fragile system deserves, so that we have a system to transform. We are also busy working to implement the large investments in behavioral health that took place in the 2019 session, and some additional investments that will be made in this short 2022 session that is getting close to wrapping up, and that we are moving in a different gear. We're working to move at the speed of transformation, and part of what this transformative process is filling gaps, so additional infrastructure that's needed. But we also want the system to work differently than it did prior to these investments, and that takes time and strategy to do that work well. And so there's been a sort of a natural tension between doing some things as quickly as humanly possible, and then moving in a different gear, so that we're very intentional and deliberate as we at OHA move towards our health equity goals and a system that works better for everyone. Next slide. So here's an overview of what I want to present to you today. So these system capacity and stability challenges that I just mentioned, and the emergency actions that we've initiated to help stabilize the system as we have it. I'm skipping the Omicron projections that were earlier in this slide because Gratefully, we're moving past Omicron, but of course, it's been front and center following Delta, and it really was necessary to push some of our strategies and our resource allocations forward. So those considerations for additional actions were in response to the ongoing pandemic, what we needed to do. The implementation updates, where I'll spend the bulk of my time. And then I think very importantly, some context around our staffing. So when I got here just under 3 years ago, you'll see that we had about 70, 80 staff, and we're more than doubling that. And I think, in part that's because of the large investment, but we really did not have the staff to manage the system that we have, much less transform it. And so we're incredibly grateful to the legislature for authorizing and funding new positions that will help us do this work and be able to do it in a way that I think will serve everyone much better. Next slide. So just a reminder where we started last session, we had conversations with the legislature about the continuum of services to the far left, the prevention all the way to our highest cost, highest intensity services around both our community hospital